Okay, so good afternoon and hello everyone. This is our 29th session of MRF HIV STI ECHO. I am your host with the most, Dr. Gregory Boyce. Thank you for joining us. We very much do appreciate it. To my left, this is my left hand, I'm so sorry, it's Dr. Selena. Todd should be doing an didactic presentation today and teaching me the basics to left and right. And to my right is Dr. David Musa, who is one of the members of our expert panel. Welcome Dr. Miriam Pabo, who will be hopefully presenting our case presentation today, and Mr. Omari Lavia, who is our data manager. So with no further ado, we shall invite Dr. Todd to begin her presentation on chronic kidney disease in persons living with HIV. Let's just pull that up. Of course, the technology is choosing not to cooperate today. Right. All right. I'm going to go Dr. Todd. Over to you.
Okay, good afternoon, everybody. Thank you for giving me the opportunity to present chronic renal disease in persons living with HIV. We start with a definition. Chronic renal disease is a change in the structure or function of a kidney for more than 90 days. Why is chronic kidney disease an issue for HIV patients? What is the relationship between kidneys and HIV? We know that HIV cannot on its own enter the kidney because the kidneys lack normal CD4s, they lack CCR5, they lack CXCR4. There's the absence of any mannose or DC signal in the kidneys. So how then does HIV affect the kidney? How does it enter the kidney? The pathogenesis would suggest that the presence of HIV leads to host cell dysfunction, and as a response of that host cell dysfunction, you have increased proliferation, defunctionation, apoptosis, which is programmed cell death, tubular interstitial inflammation, which would lead to structural damage to a kidney. Chronic kidney disease was first associated with HIV and reported in 1984. And some of us would think that's the pre-combined antiretroviral period. But it's something that's also happening in the post-antiretroviral period. And the post-antiretroviral period is from 2004 to present time. In the pre-combined antiretroviral period, which is before 1996, the classic presentation for somebody with HIV and chronic kidney disease was a condition we call HIV-associated nephropathy. It would be usually a young Black male not on antiretroviral therapy, presenting with nephrotic range proteinuria, which is more than 3 grams of protein in the urine, with CD4s usually below 200 and viral loads usually above 4,000 copies. That would require immediate start of antiretroviral therapy or some modality of renal replacement therapy. Fast forward to our present period, the post-combined antiretroviral therapy period, we are noticing, and this has been reported by Patel et al. In 2014 on a paper, we are noticing the evolution of the aging HIV person. Public Health England has stated in 2013, and this is data 7 years back, that around 27% of their population living with HIV was above 50. The CDC has quoted 20%, and even here at MRF, we have conducted an aging study, which we will release data at some point in time. So we know persons with HIV are aging, and we know about this term called HIV-associated non-AIDS condition, HANA, which consists of renal disease, liver disease, cardiovascular disease. Chronic kidney disease is one of those conditions that we have to look forward to as our population ages as a direct consequence of combined antiretroviral therapy. The prevalence of chronic kidney disease in Europe and USA is about 2.4 to 17%. It can be as high as 30% if you consider just the presence of proteinuria, protein in the urine, or a decline in your glomerular filtration rate. If we can go to slide 3, I would just want to share with you slide 4. Our own experience here at the Medical Research Foundation. We have, over a 10-year study that was done, we have noted that 663 persons had elevated creatinine above the normal range, giving us a prevalence around 9%. 65 of these patients were male. The average age among the males in the sample was 52 years. 35% were women, and the average age for females was 51 years. There was clinical significance that showed advanced age. So there was 2 times greater odds of developing chronic kidney disease if you were 50 plus than if you belong to the 40 to 49 age group. We noticed males were more likely to develop chronic kidney disease than females, 1.5 times. We also had to notice drug abusers were more likely to develop chronic kidney disease, 1.4 times more than somebody who is not using drugs. And interestingly, we also saw people from key populations and prisoners having an increased risk of developing chronic kidney disease above persons who were not incarcerated or above persons who did not belong to other key population groups. So that is just us sharing our in-house data. What are the risk factors for developing chronic kidney disease? So we could go back to slide 3. One is age, which I already mentioned. As one ages, your kidney function declines by 1 ml per minute. So by the age of 70, you already have an estimated GFR of 70 mils per minute per 1.73 meters squared, which already puts you into group or class 2 chronic kidney disease, because the filtration in class 2 is 60 to 90 mils per minute per 1.73 meters squared. So risk factors for chronic kidney disease, advanced age, and that was also detected in our cohort here at MRF. Second thing is Black race, Black ethnicities. Why is that? It's an evolutionary pattern that was meant to protect Black folks living in Africa, but with the trades, conditions and people moving, Black persons moving off the coast into the Caribbean Americas, that gene remained, but that gene no longer protects us from the condition in Africa, but now it causes issues and increases our risk of chronic kidney disease. The gene is because of polymorphism of this gene, ApoL1, which is located on chromosome 22. There's 2 alleles, G1 and G2. The presence of both alleles increases your odds of developing chronic kidney disease by 29 times greater risk. Because those 2 alleles are concerned with arterial-nephrosclerosis and glomerular disease. They were meant to protect you against African sleeping sickness, but they increase your risk of developing kidney disease now. So you have age, advanced age, as I said, just to recap, Black ethnicities. In terms of HIV, high viral loads, and literature quotes between 4,000 and over. Low CD4 counts, which is the quote as being below 200 cells per millimeter cube. And I think in terms of, they keep quoting male gender, and I think because probably it's the health-seeking behaviors of men that they tend to seek healthcare later as compared to the female counterparts, so they usually present with more advanced disease. Other causes of chronic kidney disease which we are seeing would be the HIVAN, the HIVIC, and the thrombotic microangiopathy. These are all HIV-related presentations. But the spectrum is changing from what my other slide indicated. HIVAN was seen in 1984, but in developed countries where you have greater suppression and more persons on combined antiretroviral therapy, HIVAN is actually declining. HIVAN is more common in Black and Latino population. It's actually declining. So persons are no longer presenting with nephrotic range proteinuria requiring to start treatment immediately. What in first world countries, what you're seeing is the presence of HIV, which is HIV immune complex disease of the kidneys. It's more common in European and Asian groups. And it's basically the P24 of HIV, because the presence of HIV causes your immune globulins to just increase. And it's a combination of the P24 and your immune globulins attaching to that P24 and creating a complex which consists of IgA, IgG, IgM, C3 being deposited into the kidney. Persons with HIV tend to have better prognosis, less proteinuria, less hematuria, do not usually require renal replacement therapy, have been on combined antiretroviral periods for longer, have higher CD4 counts, and much lower viral loads. The thrombotic microangiopathy seemed to be a thing of the past. It was described by Bonnet et al. In 1984. It was usually associated with opportunistic infections, but post-art, there has been no reported cases. It can start off as mild disease, thrombocytopenia, low platelet counts, renal impairment, or it can have manifestations with neurological impairments and need for renal replacement via dialysis in whichever modality. The HANA things, the non-HIV related, which is something that we would have to look out for now in the post-ART period, is the role of diabetes, diabetic nephropathy. Trinidad and Tobago, we have one of the highest diabetes prevalence. The Ministry of Health on World Diabetes Day, 14th of November 2019, quoted our prevalence as 14.5%. The prevalence of diabetes in the USA is 10.5%. Hypertensive nephrosclerosis, hepatitis C-related glomerulonephritis. We might see less hepatitis C here in our population because we have less IV drug users. Focal segmental glomerulosclerosis as a result of hepatitis B, minimal change disease. So these are all non-HIV related things that can lead to chronic kidney disease. Then the medications. Tenofovir is one of our most common medications. It's one of the backbones used internationally. Tenofovir comes as tenofovir diproxyl fumarate that we are using here. We do not have the alphenamide version as yet. But the issue with the tenofovir that we are using in our setting is that 95% is present in the serum, and that's what makes it nephrotoxic to the tubules of the kidney. In the unboosted version, where tenofovir appears in a tripler, it does not cause so much damage to the kidney. But when we have to boost, when we add tenofovir with something like atazanavir, ritonavir, where there's a booster, we know that the ritonavir as well as the colistat boost up those levels of tenofovir and it makes it more nephrotoxic. So the alphenamide by itself, there's two preparation, a 25 milligram if it's unboosted, like if it's being used with efavirenz, but if it's being used with atazanavir, boosted atazanavir, the tenofovir alphenamide is being prescribed at 10 milligrams because the dose is high and that's what's causing tenofovir to cause toxicity. So first line is a tripler, less nephrotoxic. But when we boost, and we have to consider this, especially with our clients on second-line treatment, the potential that we're increasing the dosage of tenofovir, which is basically partial to the urine on change, and possibility of increasing its nephrotoxic effect on the tubules. Other drugs that we use that can cause issues would be abacavir and lamivudine has been indicated in acute interstitial nephritis, atazanavir, urolithiasis. So those are other things that we need, and the atazanavir with also interstitial nephritis and a granulomatous nephropathy. The IV drug abuse, we don't usually have injectable drug use here in the Caribbean, but our in-house study from MRF showed that persons who use drugs, which would be marijuana, cocaine as the most widely reported drug of use among our population, was seen as risk factors for leading to chronic kidney disease. So we have already shared MRF's research. Just for renal assessment, how do we assess our patients? Here at MRF, everybody joining gets a basic urine analysis, and that's one of the criteria that they recommend, that persons, before being put on combined antiretroviral therapy, should have a baseline urine analysis. At MRF, we would repeat that urine analysis at a 2-week period and then 6 weeks. And then we do take bloods for kidney function testing and liver function at the 2-week and the 6 weeks. But internationally, in addition to what we're doing at MRF, they recommend that you calculate somebody's GFR, check the presence of protein in the urine every 3 months. If the person is on a tenofovir, you check for sodium, glucose, phosphate, calcium, bicarbonate. If the person has history of diabetes, high blood pressure, it's checked every 3 months. If the person is stable with stable kidney function, you check their blood pressure and their kidney function every 6 months. And we tend to do that even with greater frequency here at MRF. You will also aim to do an ultrasound on persons who already have established kidney disease, diabetes, high blood pressure, any history of any co-infections with viral, other viral pathogens like hepatitis C. The literature keeps recommended, but we can also do our population 10-city tech Hep B. If their viral load is persistently above 4,000 or their CD4 below 200. So just some guiding points as to how to really assess your HIV patient renal function so that you decrease the incidence of them developing chronic kidney disease. Just a quick note on biopsy dialysis, and I didn't put transplant in there, but I will touch on it briefly. When should you refer? When should you call up your friend to say, I think this person needs a renal biopsy? There are a few criteria. If there's new onset proteinuria, particularly if it's in the nephrotic range or hematuria, chronic kidney disease of the unknown cause with rapid progression, the clinical evidence of the thrombotic microangiopathy is very rare unless the person is not on treatment. The dialysis, be it peritoneal hemodialysis, both modalities are equally efficacious. There's no one that is superior in persons living with HIV. The survival of persons on dialysis who have HIV is the same to the general population. We are not, in our country, have not done a transplant on a person living with HIV, but in the US, there was 150 transplants done, and the 3-year survival was quoted as 88.2% for the person, and for the graft, 73.7%. So, in summary, renal disease started in 1984. In our era of post-ART, HANA conditions, diabetes, high blood pressure, and our aging HIV population, chronic kidney disease is something to continuously try to detect and monitor to stop off our patients from requiring any kind of renal replacement support. So we have aging population. Here in Trinidad, we are still seeing persons showing up much later than they should with more advanced HIV disease, unfortunately, despite our best efforts. We are traditionally a Black population with a lot of diabetes, a lot of high blood pressure, plus our nephrotoxic agents. So this is an area that we really need to just pay some attention to. Thank you very much.
All right, thank you, Dr. Todd. Just zoom back out to practice my camera skills. It was a really excellent presentation. Thank you so much. So I'll just open the floor to any questions while I just sort of reestablish the camera here. Does anyone have any questions? All right. So let me know syphilis. I think everyone is warming up. If you can't, we'd have to see microphone close, type it in the chat box as well. So one of the things I sort of noticed sometimes, and not just with HIV, but any condition, that sometimes practitioners get blinkered. That if someone with HIV presents with renal disease, the first place they go is not HIV. even if the person's been on antiretroviral therapy, well adherent and well suppressed. And remember, there was that case I actually asked you to intervene because a young lady just presented with nephrotic rage proteinuria and edema, hypercholesterolemia, and that didn't have the feel of an HIV-related nephropathy, even because she wasn't care for probably more than 10 years. So how do we make sure that us as practitioners don't fall the same trap and make sure that we're screening a person for renal disease, be live to the fact that our patients are running into this comorbidity, and they may
Yeah. It may also occur unpredictable gases. The first thing is to label everybody with HIVAN, and you could only differentiate HIVAN and HIVIC via renal labs, which is sometimes not as forthcoming as we would like. That's one. Two, I think the history is important to capture because HIV does not protect you from all other medical conditions. There's still autoimmune conditions in our population. Lupus nephritis is something a young Black person developing a nephrotic range should have an autoimmune screen to rule out lupus at least at minimum. But I think it's just some education on our part and to try to educate our colleagues, especially when we go to clinic, to let them know that this is the standard. This person has, and I guess we have to champion on behalf of our patients because they're the ones interacting with the physician in the hospital. So our referral letters really have to try to rebuff all the possible excuses that can come up when the patient is just alone with the physician in the hospital setting. So I think we have to champion on behalf of our patients and let our colleagues know that there are other causes. If this person is well controlled, well, HIV now is a chronic medical condition. This person is well controlled, take that off, put it in the back burner, and look at other causes. Yeah.
The other question I had was with respect to dialysis. Now, you have experience in the renal team at Plhiv. You saved many of our patients' lives, so thank you for that. So over time, has resistance placing patients dialysis changed? Because I remember very early on, it was a real struggle. But I mean, as time went on, it became I wouldn't say easier, but it was less of a fight to get persons living with HIV dialyzed. And I guess people realize that these people are going to be fine once you control the renal disease.
Yeah, I think a lot of our physician friends don't realize, again, as I said, HIV is a chronic medical condition, one. And two, yes, a couple of years ago, Plhiv Hospital would not dialyze HIV positive persons because they did not have a water system set up in such a way. So HIV positive patients were denied dialysis at Plhiv Hospital. The only center that would dialyze, and when they would have capacity, would be the center at Eric Williams Medical Complex. So I met a case of two brothers. Both of them had polycystic kidney disease, which is something hereditary. But because one had HIV, he was denied dialysis, and eventually that led to death. And the other one had dialysis, was receiving dialysis. Plhiv has evolved now. They're more in thinking. Their unit has moved. They have gotten their water system has been changed. The Northwest actually invested in a whole brand new water system, and HIV patients are accessing dialysis. At least we have about 4 patients that I can know off the top of my head that's receiving dialysis at Plhiv Hospital. So a clear champion for dialysis. I think their mindsets are changing. HIV is no longer a criteria for denying people dialysis. Yeah, but more can be done.
Do they use the same machines for everybody, or they have specific machines?
No, they have what they call dirty machines.
Well, that's what we used to call them some good years ago, dirty machines for HIV positive people, and the other machines for the other members of the public. Yeah.
But I remember even one of the nephrologists was actually arguing with some of the staff because you swap out all the moving parts. You sterilize the machine, so why do you need a special dedicated machine? And he was arguing with the dialysis nurses, and they were just adamant, absolutely not, can't dialyze. So he was just, and this is a specialist nephrologist who says, well, where I trained in the UK, we did expose to all of this drama with respect to different machines, sort of things. So I think he's still working on breaking that culture down. But because sometimes if that machine is down, if there's, and also because it's only one machine, then there's a limitation how many patients can be dialyzed.
Mount Hope has separate rooms set up, separate closed rooms, especially for people who have hepatitis. But I think people don't seem to realize that hepatitis is more infectious than HIV.
Right.
So much more infectious than HIV. Yeah.
It has a good name.
I got you.
Exactly. That's a good name.
Any other questions, anyone?
Now, there are a good number of patients who present to casualty and then they're dehydrated from diarrhea or from chronic illness or whatever. And then they go into hospital and they have impaired renal functions.
Mm-hmm.
And they're also HIV positive.
Mm-hmm.
And they're started on that tenofovir and on abacavir, lamivudine, and efavirenz. Is there room for these people to revert to a triplet?
Yes.
And when?
There is room for them to revert. If they have stable kidney functions, I think within 90-day period, I think they can be reverted. Because you don't want to, they've had that, you put them back on in tripler, and then if you do put them back on in tripler, like after they get IV fluids and their kidney function has resolved, if you put them back right away, I think you just have to monitor them very closely over a 3-month period. You have to be very close with their monitoring. If their kidney functions remain stable post-hospital discharge, being exposed to tenofovir, fine. But if you monitor them within that 3 months and there's any change, for example, within that 3 months, if their GFR should be below 60 mils on 2 consecutive periods within that 3 months, then they should be discontinued. So at least you've given them the benefit of the doubt. You move from polypharmacy back to that single tablet. But if there's any deterioration within that 3 months, you've already given them that trial of treatment, then you should be safe and just maintain the renal regime of abacavir, TTC, and Stockryn.
One other thing you didn't mention are non-inflammatory NSAIDs, which can also lead to renal problems. I remember one basketball player in America who took his doctor to court because every time he was in pain, he would get injections of NSAIDs and eventually had impaired renal functions.
Yes.
Yeah. And we use painkillers quite a bit also.
Yes, I always advise patients short term. If you have chronic pain that you're living on diclofenac every day, there's a problem. We need to intervene and refer you to some specialty. Yeah.
And in the UK, I mean, you can't get more than a certain number of non-steroidal without a prescription.
Yes.
We get with a lot in Trinidad that just because, I mean, I had the experience, my mother's chronic pain, and she went to the UK and she just medication and she could not get anything. She actually had to refer to a friend of mine to get a prescription for diclofenac.
Yeah. Even ibuprofen 800 milligrams in the US requires a prescription. We could go in a pharmacy and buy 800 milligrams. If you're getting ibuprofen in the States, you're getting 200 and 400 milligrams. Yeah.
Goody.
Well, again, fabulous presentation. Thanks
very much. Thanks for having me.